You heard this morning in some of the presentations the importance of the legislation that was signed in around 1972 that actually is the only condition for which the U.S. government categorically pays for care. And it came out of course, a very difficult time in the beginning of the dialysis industry. That has morphed many, many times and changed over the past couple of decades. And we're now at a point where we're trying to figure out what's the best way to pay for care for these patients and how do we manage, not only in the United States, but here also a global perspective. We're trying to provide optimal, efficient care, do so that is centered on patients and also does not break the bank, which can happen in certain situations. So we're going to hear from 4 people. And the way we're going to do the panel, they're all virtual. They can't be put up on the screen all at the same time, unfortunately. So I'm going to turn each of them first to introduce themselves very briefly. The last person will talk about the experience recently of the Center for Medicare and Medicaid Services in the United States, about some of the innovations they've tried to do. And then they're going to answer a couple of pretty important questions. They're not only going to talk about what we think of as value-based care, but they're going to try to say what is in value-based care for them in their system. They're going to talk a little bit about the pitfalls and concerns about trying to implement these various payment structures. And then we're going to talk about how value-based care feeds into or actually requires innovation as we go forward. So I'm going to start with George Hart, and the way this happens is when our speakers speak, they'll pop up on the screen. At least that's what I've been told. And let's see what happens. George, if you say a few words about yourself, please.
Sure, Larry. Thank you. I'm George Hart. I'm a nephrologist in North Carolina and the managing partner for a large practice there. We had participation in value-based care with the ESCOs and now with the CKCC models. And I'm the co-chief medical officer for Interwell Health, which is a renal-focused value-based care company.
Thank you, George. Jay Agarwal.
I'm Jay Agarwal. I am the Chief Medical Officer for Satellite Health for population health and value-based care, nephrologist by training, and I oversee all our efforts regarding to value-based care and population health, including KC in Northern California currently.
Thank you, Jay. Marcello Tonelli.
Hi, I'm Marcello Tonelli. I'm a nephrologist in Calgary, Canada, and a clinician scientist. I have to admit that value-based care is not a very familiar term to me per se. But as someone that works in the universal healthcare system, I think we've always tried to consider value in one way or another. Looking forward to the discussion.
Thank you, Cello. And last but not least, Lina Gebremariam. Helena, after you introduce yourself, please give us a few words about what CMS has been doing and the concepts of value-based care. Lina?
Yeah, thanks, Larry. So again, I'm Lina Gebremariam. I am the co-lead for the Kidney Care Choices model, which is a value-based care demonstration run out of the Center for Medicare and Medicaid Innovation. So when we talk about value-based care in CMS, typically the focus has been on primary care. The idea that the primary care provider is that quarterback who's going to coordinate care across specialties and across settings, and that because they see the patient most often, they'll have that care relationship and they can work with the patient to manage their overall health, and that we can tie financial compensation to the provider and ensure higher quality care for the patient. Demonstrations such as the Medicare Savings Program have been running for 10 years on this model. But what we've been trying to do more recently is challenge it a little bit. So as you all know, when a patient is diagnosed with ESRD, that's going to supersede any other kind of healthcare in their life. The primary care provider is not going to be the person they see most often because they're going to be in that dialysis facility several days a week for hours on end. So the first demonstration that we've tried is called the Comprehensive ESRD Choices Model. And this idea was to create accountable care organizations, not centered on the primary care practice, but centered around the dialysis facility where that patient's spending the most time. So we asked dialysis facilities to form accountable care organizations with nephrology providers and other Medicare suppliers and providers, and coordinate care in such a way that we can improve the quality delivered to patients while also reducing per capita costs. Now, the CEC model ran for 5 years, and it just ended in 2021. And we had some promising results, but we wanted to expand the test. So in January 1st of this year, we launched the Kidney Care Choices model. And the Kidney Care Choices model is built off the CEC model in that we are looking at kidney care focused ACOs. But rather than placing the dialysis facility at the center, we're asking nephrologists to take on that primary care provider role and to really be in charge of coordinating patient care. And the reason for that switch from dialysis facilities to the nephrology provider is also that rather than just incorporating beneficiaries with ESRD, we're also incorporating beneficiaries with late stage CKD. So that way, we're hoping that by managing patients earlier in their journey, we can prevent them from crashing into dialysis and can actually delay the onset of dialysis and keep them healthier for longer. So this demonstration is going to run through the end of 2026. This is the first year, and so we're really excited about it. We have over 8,000 providers participating, covering over 150,000 Medicare beneficiaries. And so I'm going to stop there because I'm sure we're going to talk a little bit more about it and hear from some of those participating in the model. So I'll kick it back to you, Larry.
Thank you, Lina. I'm going to actually take the moderator's prerogative and ask you just one question.
It's a little hard to hear, sorry.
Oh, sorry. Can you hear me now? Is this better?
A little.
Okay. So I'm going to ask you just one question. What kind of lesson did you learn from the CEC model that you've tried to incorporate into the new next 4 or 5 year model that you're now working on, the kidney model?
Great question. So I do think that we learned that once a patient is already experiencing dialysis, there's still a lot we can do for the patient, but we want to prevent the patient from ever starting dialysis in the first place. What can we do earlier upstream to improve patient overall health and keep them healthier for longer? So that way that clock doesn't start ticking until later, and we can keep them healthier for longer. The KCC model also is working to incentivize home dialysis as a differing treatment option, as we've had a lot of Medicare beneficiaries have issues with transportation, with getting to dialysis facilities regularly. And so we're hoping that home dialysis can prove to be a healthy alternative for them. And we also have incentives built in for transplants, hoping to incentivize the kidney transplant process and help providers work with their patients to get them on the wait list and keep them active.
Thank you so much. We're going to turn first to George Hart and then Jay. And then, Cello, I'm going to ask you some very specific questions because I know you're in a very different environment than everybody else. George, talk to us a little bit about your perspective on value-based care and what you guys are doing to try to bring the most effective therapies to your patient population, et cetera.
Sure. And I'm going to preface in advance that Lina and I did not rehearse and didn't meet beforehand because I'm probably going to say some of the same things that she would say if she were still talking. And I agree with all that she just said. I've been a nephrologist for 30 years. And, so many times what happens is there's a failure or a poor outcome because of an inability to get a patient from A to B. And A to B could be a physical A to B, transportation failure. It could be an understanding failure. It could be an inability to overcome some of the social inequities that we know impact care. I think what these models have done, first with the ESCOs and now with the CKCC models, is they're putting tools back in the hands of nephrologists. They're allowing us to think outside of the box, be creative, take risk on being able to do things further upstream. And I think it's a significant change in these two models that we're now looking at stage 4 and stage 5 CKD. We're looking at transplants. We are valuing the ability to provide what's called an optimal start, where we, create a glide path for patients so that they don't crash into dialysis. We're emphasizing preemptive transplants. We're emphasizing home therapies. These are all good things. They're healthy things, and they're decisions and focuses that nephrologists can get behind and embrace. So I think all of us that are involved in these models are quite excited about it. we think this model in the CKCCs is somewhat clearer in focus for us than even the ESCOs were. But I think as we are also restored to the centerpiece of care, we nephrologists realize that the care that we provide is valued, and that we're allowed to have more of a say in what happens than we have in the past. So I think bottom line is I think the changes that we see now with the CKCC models are all allowing us to do things further upstream, do things that make sense, emphasize education and care navigation, which are proven strategies to help cut cost and benefit patient care.
Thank you. Jay? Same question.
I would echo the comments of George and Lina as well. I mean, I think when I look at value-based care, it's about doing what's right by patients and really empowering patients as well as empowering nephrologists, moving from nephrologists from being dialysis doctors to being kidney care doctors in itself. I would say in our process of doing that, though, although all nephrologists want to be empowered, the truth of the matter is it really is practice transformation. And so that's a difficult thing that takes time. And I think it's something that the nephrology community is going to have to grapple with, that actually it is work. It is how we change and how we do things differently. It's not something that can be done to the nephrology community. The nephrology community has to take an active role in it. And so I think, that's part of what we need to do, is to really move beyond, the buzzwords of value-based care and really understand what does it really mean for a practice? What does a practice have to do on a day-to-day basis? I think those are all the things that George and I and others that are running these programs deal with. So I'm excited, and I think that we're going to get there. But I do caution everyone that and I tell people it's a journey. It's not a sprint. We're not going to be there tomorrow, and not every practice is a 30 physician or an large academic institution. So, but I applaud CMS for helping ushering us along that journey.
Jay, let me ask you, you did mention the journey that you're on right now in terms of value-based care. What are the obstacles you see in that journey to making sure that this is effective with these new tools in the hands of nephrologists, but also effective for patients and the healthcare system? What are those challenges?
Twofold. One, I mentioned, the sort of provider engagement. I think that takes some time to get to. But secondly, even collaboration amongst organizations, whether that be from a data or process standpoint. All of us, have some degree of data analytics and data sharing, being able to make sure we're sharing that well between hospital systems, between dialysis providers, between providers and EMRs. Is still an area in which we still have a lot of work to do. We definitely made large strides in it, but getting there. And then thirdly, I think it's patient engagement. So how do we build upon that and actually we do a lot of, patient activation measures and screening scores that'll help to guide us and help to learn what type of best activities we can to engage our patients. But we do need to also engage the patients along the way.
Great. Thank you. Great answer. So, Cello, I'm going to turn to you and know that you're in a very, very different system. So providing value to patients and to your system is probably a little different for you. Can you just give us your perspective and where you think this is headed as well?
Well, I think I've been grappling with the idea of value. What is value? We've heard some of the other panelists say, by the way, I agree with everything that my fellow panelists said about what is important. I think we have a very common view. The only thing I might add is, who is it that's deciding on value? Whose perspective are we taking? Who chooses what the value is? And when I think about that, I think about the opportunities to align what patients might see as value with what the system and providers might choose. So one example that comes to mind is something like incremental dialysis. So we all know our patients, if given a choice between dialyzing less frequently and more frequently, if it's going to keep them healthy, most patients are going to choose a little less dialysis. That's an example of where value and patient wishes can align. And I think we need to look for those easy wins. A modality of dialysis choices where home dialysis is more freely available for those who want it is another example of how those things align. I'd like to also just make mention about providers. I think the sense I get is that value-based care could be something that's done to providers. We're talking about providers participating in that, guiding it, and that's good. I think that values should recognize the important role of providers also. We need to protect our workforce. We need to ensure that people want to become nephrologists, want to participate in this. So we need to ensure that, in my opinion, that whatever value-based changes we make don't make it less palatable to become a nephrologist, a kidney specialist. We need to think about that. How can we align payment structures, workflows, and so on to make nephrology the great specialty to work in that probably all of us think it is? I could go on. Thanks.
I wish you would go on. Let me ask you all a question. You've talked about empowering nephrologists and making sure that they have tools at their disposal. Where do we see patients in the role of value? And I'm going to leave it open to all four of you. Anyone can choose to talk first, and your name and you'll pop up. But where are the patients in this from any of your perspective?
I can take it. Patients, I think patients are at the center of it, but I think getting the patients to understand that, truly understand and be educated about their current status within, whether it be CKD and ESRD, and education of patients is paramount. I think our patients trust their physicians, but many of them may not be as engaged as they may be. So how do we educate patients to get them better engaged? I think is a critical piece of whatever we're trying to accomplish.
Yeah, I mean, I would add that what we're really trying to do is to get patients to be an active participant in their care, so that the care that is unique to them is care that they've chosen and been a part of deciding that they want to do, so that the life journey for not just them, but for their families, optimizes and maximizes, what their life can be, having to deal with kidney disease. So I look at some of this as the patient journey as truly being part of the value proposition here. I think we can make it better.
Lina, I want to ask you about the CMS perspective on patients and how you have, if you have, included them in the revised models that you're trying to promulgate in the community.
Yeah, well, I think how, Marcello said that sometimes value-based care is something that's done to providers. Sometimes patients can feel that their care is what's done to them, rather than being an active participant. And so, the more that we can increase healthcare literacy, the more that we can increase patient engagement, the better it is. And so the way that we've been trying to incorporate more in our programs is by increasing the use of patient-reported outcomes. Having the patient define what value is and what they've seen in their life that they want to change. Something that we've also seen a lot in our dialysis patients is the high rates of depression and decline of mental health. So we've incorporated some behavioral health components into our models as well to help patients grapple with that completely different part of their care that's going to be a reality of their lives on dialysis.
Great, thank you. So I want the audience to get ready for questions in a few minutes. I'm going to ask our panelists one additional question. When we hear from them, then the floor will be open for you all to ask them questions about value-based care and the topics in front of us. The question I'm going to ask, and I'm going to start in reverse order. So I'm going to start with you, Cello, and work my way back through Jay and then George and then back to Lina, is about innovations. What are the innovations that we need? Technically, payment, healthcare system, you name it. But what do we need that's going to increase the value for both the patient and the nephrologist and the healthcare system that will really make it work? Because what we're about here is innovations. You've heard about xenotransplantation. You've heard about Bill Fissell and his team trying to create a biological kidney. So what we can do that would really make a difference in the value domain? I'll start with you, Cello.
I think reflecting on the changes in kidney care where I've worked for the last couple decades has been referral mechanisms, timely referral, early referral. We went through a period where we haven't solved all these problems. I don't want to give you the idea we've solved them, but we don't have the same proportion of late starts. I don't hear it as being a major issue, crash starts. The reason for that is with one health system and one lab-based set of prompts, anytime someone gets a GFR measured, it's recorded. And so we've gone through a period 15 years ago where we had too many referrals from GFR reporting. We couldn't manage them all. And that forced us to develop a better, more integrated system with primary care practitioners, more co-management of those people with stage 3 disease, then moving into a mechanism for who should be referred with albuminuria and GFR heat maps and so on, all the things that we're familiar with. But that, I think, had a huge impact because it allowed us to get the people into the system earlier, patients into the system who needed specialty care, and allowed that funding for multidisciplinary care. And I think that's the one part that I would add. We've talked about nephrologists, patients, funders, but in my opinion, to really move the needle on value-based care, you need the whole team working with the patient. That's not going to be nephrologists that are going to be the best at identifying those patient priorities. That's going to be our allied health colleagues that are going to do that, developing the relationship over time. So I think that's the one thing that I would really point to. And then you, as a goal, and then you will need workforce-based interventions, payment-based innovations, and a little bit of tech, I think, to support that. One final note would be that the thing is, once you get someone into the multidisciplinary care clinic, the patients that make most of us sweat the most are those that are close to dialysis. They're in the system, they have a low GFR, they have some symptoms, but they may not need to start dialysis. And that's where I think some innovation around payment might be very helpful to pay at. I mean, really, the management of those patients should pay more than dialysis. It's harder, and there's benefit for everyone, patient and health system, to keep them off dialysis longer. So we've been experimenting with some ideas in that space. I'd be interested to know if you think that could work in the US context. Great question. Thank you.
That's a great comment. I actually think it's an area that could work and something we should talk about. You mentioned a transformation in your system concerning referrals. Is that available publicly? Could we find out how you've made this transformation and sort of think about how we could apply it into our models?
There are some papers that describe it. There's no narrative paper that I can think of, but I was at a KDIGO meeting recently at which this came up, integrated kidney care. It's got me thinking we should write about it a bit more. The one paper I would point to is Brenda Hemmelgarn's paper from, I think, 2009 in JAMA that talked about the impact of GFR reporting on referrals. There's some other papers that look at that, and some from the Ontario group. But I think it's something we should think about exploring further in writing.
Great. Your suggestion about trying to catch patients in that peri-dialysis period, right before, and emphasizing that and trying to figure out what's value there for the patient and the system is a really clever idea. Thanks for that. I'm going to turn to you, Jay. Talk to us about innovations and what do you think would be a priority?
Yeah, I think really that when I think of innovation, it's really on innovation on process and workflow. And if we look at building on, in addition to this advanced CKD individuals, those that are either new to dialysis, those that are post-acute, so post-hospitalization. So how do we innovate in workflows and staff, and that way we don't treat that patient like any other patient within a dialysis unit or even within our practice, within a CKD practice, someone that's recently been hospitalized. How do we actually have workflows to do a true transition of care, visit from this meaningful? I think there's lots of ways that we can innovate just within the processes, not necessarily, top of mind is not necessarily needing a new technology. I think we have a fair amount of technology, but we need to really think about our processes.
George.
I'll say three things. I think the first is recognizing that the first innovation really just has to be a cultural shift in the way that nephrologists think and how we practice, realizing that we have 1 foot in fee-for-service and 1 foot in value-based care, and the skill sets you might need to be successful in one arena don't always translate over to the other arena. I think the workload is a problem as well. The second thing I would add is we need better data, and we need more timely data. We need to be able to be more nimble, and we can't wait for the lag that comes with claims data to be able to look at how we're doing. And the third component is I wholeheartedly embrace the idea of working with allied professionals, and particularly, advanced practitioners. My practice has 45 physicians and 40 advanced practitioners. And, we've embraced that idea and found it to be very successful. Patients like it, better outcomes. And I think as we grapple with the challenge of a diminished nephrologist workforce, we have to think differently, and that's a natural way to go.
Great, thank you. And Lina, I'll turn to you last. What's CMS thinking about in terms of innovation? I'm sure you're thinking about value and payment models, but maybe there are other innovations that would be attractive to you and you think would be meaningful for our community.
Yep. So we're definitely thinking about payment innovation and how to, have the nephrologist be at the center of the patient care. We're also thinking about how to bring health equity to this process as well. I think health equity has been something that we've, started talking about more as an industry. ESRD is something that greatly affects some populations more than others. And so where are we not meeting the needs of everyone, and how can we increase that? There's been conversations within the community about the use of the EGFR and eliminating the race factor. Things like this are continuing to evolve in how we think about dialysis care. I think also we can't talk about dialysis care without talking about transplant care. Dialysis has a time limit. And so we're thinking about how kidneys have the longest organ wait list of any organ. So how are we going to increase organ supply? How can we keep patients active on the wait list while they're waiting? I think that's the next step.
One thing you didn't mention I'm curious about is the perspective for any of you, but maybe starting with you, Lina, on home dialysis. You've heard from our panelists this morning, I don't know if you were able to join, but early this morning we talked about the COVID epidemic and patients who were forced to go into center 3 times a week and put their lives at risk. And in fact, were seen to die at high rates. Higher rates than for people who were able to dialyze at home. Where do we think about the home picture in terms of innovation and in terms of value? Or are they disconnected issues? I'll start with you, Lina.
No, I think they're very much connected. One of the demonstrations that I didn't talk about earlier, we call ETC, or the ESRD treatment choices model, in which we are reimbursing for home dialysis at the same rate as in-center dialysis to help providers get the resources they need in order to set up home dialysis for their patients. Because the more flexibility there is in a patient's dialysis care, the more flexibility they have to lead some semblance of a normal life.
So I think I heard the question as focusing on the handoff from primary care or referral into the dialysis system, right? Okay. Anybody want to take that from the panel?
Larry, I'll start. I think it's a great question. And one of the struggles that, I think we've all dealt with and what Cello was mentioning earlier, too many referrals, just right amount of referrals. What we're starting to look at is, how do we create a co-management strategy that the primary care doctors are comfortable with, because they have the ability to address certain comorbid conditions better than we do as nephrologists. I'll just take behavioral health as an example. So what we want to do is not have that handoff be, like handing the baton, but actually be partnering together as we move forward and how to take care of these patients. So the primary care doctor doesn't feel like he's out of the loop and has lost touch. And the nephrologist knows that he has the support of someone who can manage some of these comorbid issues, better than we can.
Great. Thank you very much. Any of the other panelists want to comment on that?
I'd like to just add, I completely agree with what George said. The comment could be, we are starting to think about how might we move some of those things into the dialysis unit. So if there's a primary care practitioner or other specialists that are involved, whether they're the quarterback or other specialists, those are other trips for patients that are very busy and burdened already. We've talked about hubs of care. There are some not demonstration in the CMS sense, but local demonstrations, embedded GPs, embedded primary care practitioners in the dialysis unit that have those skills, together with the physical setting to allow those visits, like a private room when you want to have a conversation about mental health for the dialysis session. Something that we haven't done but are thinking about doing is having attachment of cardiologists or endocrinologists for those comorbidities that are so common in our patients, to avoid extra visits outside the dialysis unit. It will improve, we think, physician-to-physician communication, but it should also improve the patient experience. It's another one of those examples of aligning what the patient is looking for with our attempts at value.
Perfect, Cello. Thank you.
Dallas. I wanted to extend the conversation a bit on a point that both Lina and Marcello touched on, that is the patient's perspective of value. And so it occurred to me when I was taking care of patients who were on dialysis, I had an external driver in terms of payment for making sure that their biochemistries were taken care of. And my own organization focused on the length of lives of our patients. And so we focused on things that would extend the quantity of their lives. But what my patients talked to me about was the quality of their lives. And it occurred to me as I listened to this conversation, at least then, I did not have a driver, an external driver for improving the quality of their lives. And so I'd like if the panel can talk about that potential innovation.
I bet everybody wants to comment on that, please. Don't be shy.
I can kick it off from a CMS perspective. Thank you so much for the question. So I agree. The patient experience of care is one of the most important things. They need to define quality for their own care. A patient who is trying to maintain a full-time job is going to have different outcome desires than someone who is trying to see their grandkids grow up. And so by incorporating patient-reported outcomes and measure sets, we ask that patients define what they want to see out of their care and ask providers to partner with them to help them see that through. So if it is pain management, or if it is time spent outside the facility, having the patient really dictate those terms can be really helpful.
In a minute, Lina, I'm going to follow up with you, but I think George might want to say something. George?
Sure. I think it's the kind of the fundamental point that we would all like to see better, which is have our patients, have an optimized life while they're dealing with all that goes on with kidney disease. I think it starts with education. I think it starts with being able to expand not only who can provide that education, but when patients can receive it. So that's part of what I like about the new CKCC models is some of that's been addressed. I think we all have to slow down and realize that taking the time to listen to patients, reaching out to their families, who's the appropriate person to have an advanced care plan meeting to give everybody a chance and for patients to express, what they want or what they don't want. Those kind of opportunities are, I think, part of what we are all kind of trying to address and figure out what's appropriate.
I was going to make a comment and add on to George's comment that I do think this is to address this. It takes time, and I think one of the issues is that if you look within healthcare within the United States today, especially nephrology care, having providers to have that time to be able to sit down and have those conversations is difficult to do and is not always a great skill set for every physician as well. So a lot of these programs are able to create more time with the patient to have the bandwidth to be able to address these issues that really do take more time.
That's a great comment. There are two more questions from the audience. We'll take those two and then we'll wrap up. Please.
My name is Eric Ditchman, and my question is for Ms. Gebremariam. Thank you for the presentation. I've been on home therapy since 2001. I got this survey from CMS in June, and I was excited because it was about my clinic and all kinds of great information. But when I got to question number 1, it asked whether I was in center or home. When I chose home, it said go to question number 45, where they wanted to get some demographic information from me. So I guess, when will I get my survey to tell you how things are happening for me on home dialysis? Thank you.
This is not a plant. I swear, Lina, we did not plant that question, but you still have to answer it.
Well, thank you for the question. And to be honest, I'm not 100% sure. but we are always looking for patient input. 1-800-Medicare is manned by humans who are looking for beneficiary input every day that we then incorporate into our models. We ask our providers to reach out to all of their patients and measure them on the number of patient responses they get, both halfway through the year and then again at the end of the year. So I would ask the nephrologist that you work with, and if that fails, then 1-800-Medicare will be your best resource.
Thank you, because I threw it away. I said, you don't want my info, but thanks. I will talk to my nephrologist. I'm sure it was his fault.
And
no comments.
and Lina, I think what you're hearing is from the patients and our advocates who attend IDEAs. They feel passionate about this, and if you haven't heard from your home patients, spread that around. I'm sure someone will be very interested in hearing from our home patients. Last question, Steve. Thank you.
Yeah, Steve Ash again. I guess this is a question for Ms. Gebremariam again. You mentioned that you'd like to see CMS incentivize home dialysis. Most home patients are on machines which are designed really for short treatments, but more frequently during the week. 4 and 5 times per week is the usual schedule. If the patient's center sends in a bill that includes 4 treatments per week for that patient and has no other diagnoses, then that treatment is really based on the fact that this is the best therapy for uremia. And my question is, does CMS pay for 4 treatments then, or 3?
So right now, what we are doing in some of our demonstrations is trying to reimburse home dialysis at the same rate as in-center dialysis. So currently in the Medicare program, in-home dialysis is reimbursed at a lower rate, and there are a lower number of sessions that are paid for. We are actively trying to change that. And in all of our voluntary models, as well as the mandatory model that we're testing, the ESRD treatment choices model, home dialysis and the reimbursement level of that is a big initiative.
Yes, and wouldn't you say that this is a disincentive for home dialysis, meaning the center themselves have to make up the cost, and they'll complain bitterly if the doctor and the patient decide for their best interest to do 5 treatments a week?
Thank you. And yes, this is something that we have in all of our demonstrations ongoing right now, and something we're looking to change in the future.
We very much support that. We're at the end of the session. Please, audience, let's thank our 4 panelists. And my thanks to Lina, Cello, George, and Jay. It was very enlightening. And hopefully the things you talked about in terms of value-based care and trying to provide better care for our patients and making that synonymous with patient-centered care will be a reality in the future. We really appreciate it. Thank you all very much. And now, Buddy, we'll introduce our last panel of the day.